quickly, gang, let's cover the sort of very complex world. There is no book to read. You've got to figure it out on your own. Is how do you deal with patients with regional metastases where your goal is, lofty and maybe even curative in nature? And we've got pretty good data around liver disease, but we're talking about peritoneal disease now and other modalities. Marwan, how's it handled at your place in terms of deciding how to manage these patients?
So for liver disease, I have to say our center, we're blessed to have the ability to have pumps. And so we have been using hepatic arterial infusions in high-risk patients.
So you're one of the 4 places on the planet
we're one of the few places. So I mean,
anybody else doing that?
I'm sending patients to New York.
Yeah. We send them to New York. There's a train that takes them to New York.
So for the regional disease, I mean, I think that's probably a 3-hour session, because what is regional disease? It is potentially resectable. Is it resectable now? Is it high risk of recurrence? What is your risk stratification for recurrence here? What's your CRS score? And so all of these factor in what you want to do for the patient. But if we're talking about regional disease, adjuvant therapy, we do kind of discuss these on a multidisciplinary setting. If it's liver only, we think the patient has a very high rate of recurrence in the liver, such as 4 or more lesions. We are considering some of those patients for hepatic arterial infusion placement.
You're impressively consistent because you're embracing the left side of EGFR, survival advantage, FOLFIRINOX, survival advantage, infusion pump, survival advantage. I mean, they're all a pain, and they're tough to manage, and they require a lot, but you're really going for that OS, where I think the rest of us are saying, well, it's just hard or it's complex and it would require major changes. And I know you guys have seen the fact that they've stopped making these infusion pumps.
Correct.
So we have to figure out how to, for those folks who are still doing that, figure out how to do it. Is there any patient that really should get Y90? Well,
so there are, the answer to that, short answer is maybe. And by the way, I won't.
Such a weenie answer. I'm going to go to somebody else.
I won't take it. I live in the West, so all these comments about wild, wild West, I'll let them fly. So I think first of all, you have Messersmith, which are low-dose radiation regional, and there's the Foxfire and Surflox trials, which are essentially negative.
Frontline.
Frontline. So that definitely dropped off our use of those in the frontline.
Do you believe the
setting.
right-sided subgroup on that?
Again, I think it's hypothesis generating. I'd want to see something prospective. Yeah. Theraspheres, which are the high dose, very targeted radioembolization techniques, those trials are ongoing. There's a second-line trial that we're participating in, and we're still on occasion doing that. I will say that over the last 18 years of doing this, the ability to resect lesions has become much more in terms of really worrying more about the future liver remnant, what you're left with rather than what you have to begin with. Portal vein embolization, allowing the other side of the liver, for instance, to hypertrophy and have a greater future liver remnant. So we're certainly more aggressive about resections than we were before, but our radioembolization rates have dropped considerably since the publication of those trials, just following the data.
Yeah, we use them, I think, a lot in that refractory space and liver-dominant disease. Particularly, I mean, a lot of us are phase 1ers up here, is that you see that patient from outside, a lot of disease in the liver while you're waiting on the slot, or you need a new biopsy to prove a marker. You go to IR, you get a little biopsy, you get a little Y90, and then 4 weeks later you're good to go. Is that y'all?
Well, I just think it's just interesting though that we work in an industry where we buy a Lexus and we're just not sure if it works. You might turn the key, it might not work at all, and you're just going to get out and walk away.
Tesla.
Yeah, exactly. So
if only it were a Lexus.
So I think we just have to keep that in mind, is that there's only enough money in the till, and if these things are really expensive.
My world, I come from High-Techville, where Sugar Baker started the business in the Washington, D.C. region, so we're very heavy-handed. So I'll defer to you guys to set me straight a little bit. Gabriela, do you think there's a role in colon cancer for HIPEC? Do you send patients sometimes for that?
I actually do. So for those select patients that don't have visceral disease, they have peritoneal carcinomatosis, I typically start out with systemic chemotherapy, but I do want them evaluated serially by a surgeon expert in cytoreductive surgery and HIPAC, and more often than not, I'm being told the patient is not a good candidate, the burden of disease is too high. Oftentimes I say, let's wait for 6 months, do a laparoscopy, look at their burden of disease. I would say very few patients are good candidates for HIPAC, but those that are, I would not hesitate to refer them.
Counter to that, anybody? Is there a case to be made?
We actually offer HIPAC in our center as well, but we're quite selective. I think we're all awaiting the data to see how much does the hyperthermic chemotherapy add to the cytoreduction. I think that's a very important question. This is not by any way an easy procedure. It takes about 2 to 3 months for patients to recover. Fully. They have significant discomfort in the abdomen that continues for about 8 weeks or more. It's not easy to go back on chemo. So I think it's important to look at the carcinomatosis score in those patients and only limit it to the patients where the data has shown that you make a dent. And I have to say the cure rate is going to be very, very, very low. And what you're doing with this procedure is you're just moving, you're basically improving survival, maybe, and at the same time, I think it may have a palliative role because these patients will die with bowel obstruction, and if you are able to delay bowel obstruction by preventing, progressive carcinomatosis, that by itself may be an important endpoint.
Yeah, I think as imaging has gotten better, surgeons gotten better, and recovery has improved, I would say our shop, they seem to recover a little bit better than you described from these big surgeries, that we've gone away from surgery as a curative modality, although you try it when you can, to one that's just resetting the clock, and back to no evidence of disease. And if the surgery is feasible, and this is true for whether it's Y90 or stereotactic radiation or RFA, we're playing a lot of whack-a-mole out there. Is everybody doing that? I mean, that's where we are. And so the question I have for you guys is, okay, now what? So they come back and they're stage 4, no evidence of disease, maybe got some pre-op chemotherapy. What do you do now? They have a very high risk of relapse in the 80+% range. What do you do now?
I don't send them to you because I don't want to get maintenance capecitabine.
Come on. So what do you give them?
Yeah, so
you don't give them FOLFIRI, I
these
trust.
folks, absolutely. So most of these folks, like you said, a highly selected patient population, right? So most of them have gotten
them, right? More and more of
absolutely,
these people,
but
right?
most of them have gotten at least 6 months of therapy,
Yeah.
sometimes 12. So, and I agree with you. I think we're probably, the curves often don't flatten, but we don't have chemo curves that have 60% 5-year survival, plain and simple. So what I often tell patients is, like you said, you're kind of resetting the clocks, probably going to come back. I have seen some patients cured, probably going to come back, but boy, you can have 3-4 years off chemo. So to my mind, half the point of doing the surgery is to get off chemo for a while, stop seeing me, stop the copay, stop the all the stuff with chemo, and just kind of give them a break. But we don't have data. It wouldn't be. I think you can also make a cogent argument for some type of maintenance approach given the high relapse rate. And so it's a great.
No,
question.
I'm not trying to advocate for it necessarily, but I'm lost. I don't know what to do. And what I am seeing is a lot of people giving another 6 months of Folfox or FOLFIRI, or which I don't feel good about because I don't think it's going to have the adjuvant effect that they're
so what
going for.
we're seeing, John, is basically a shift also in a higher risk population undergoing that procedure. And I think those are the patients who are relapsing very quickly. And I think in those patients, one should certainly, if you are doing the procedure, you should certainly think about maintaining those patients on chemo. And perhaps we should start stratifying our patients a little bit better as to, okay, you've only got 2 peritoneal implants and I've resected them and I've done HIPAC. Well, what's the point of keeping you on chemo for good?
It's a great point. I mean, and our surgeons won't do it. And by the way, this is not something you want to dabble in. I mean, these people really have to do this full time. But unless they can get a CC0, so complete resection of all disease, they really try not to do it. And I often feel badly when I see a second opinion. Someone's had a CC2, visible disease left behind. What have you really done for that patient?
It's a really great discussion in a difficult situation, and it's very hard to write down what the right answer is. And I think that makes it also very hard to design trials because they're so variable, the kinds of patients that end up stage 4 no evidence of disease.
I've quoted you before to my patients saying there's kneelers and there's standards. You either believe or you don't believe.
You believe or you don't believe.